will cover the culture content that I went on. It will cover elder abuse, child abuse, intimate partner violence, and sexual assault. Okay? Minimal pharmacology on this test because the only thing that you really are going to see pharmacology-wise is Plan B, and we'll go over that today. Okay? And there was a reading in your farm book about that. All right. Questions? Can you repeat that? The test was yeah, it's everything that I have covered in 212 is the culture, the elder abuse, the child abuse, the intimate partner violence, and the sexual assault that we're going to go over today. Minimal pharmacology because there's just not that much. All right, let's do it. One of the things that I have put up here are the two numbers for CVAN, Camaris Victim Assistance Network. This is the number for CVAN for people in Camaris County that have been battered. With Rowan County, it's the Rowan Crisis Council. This is their number. They both have 24-hour hotlines for people that have been battered or abused. And I just give you those as a reference. If you work in the emergency department, I'm sure that they're posted pretty much everywhere in those units. But it's always a good number to have on hand, either for yourself, for a family member, or a friend. So, one of the things that you find is that both of these places have websites, but the women's shelters, the address will not be listed. You will have to make contact, and then they will give you an address for you to show up, or they will come and get you at the emergency department. Okay? Unless you volunteer at that shelter, it's not an address they give out for obvious reasons. All right, so what we're going to talk about is intimate partner violence, and really that has sort of become the catchphrase instead of domestic violence. All right, whereas domestic violence indicated that there was a legal relationship, man-wife. Intimate partner violence basically is a sort of catch-all term, and it talks about significant others of all sorts. Okay, so you may be man-wife, it may be teen, girlfriend, it may be whatever, but there has to be a relationship between those two. It's not just a random assault. Basically, when you look at intimate partner violence, it's a pattern of assault and course of behaviors that may include physical injury, psychological abuse, sexual assault, progressive social isolation, stalking, okay, deprivation, intimidation, and threats between current or former partners of an intimate relationship, regardless of gender or marital status. And this is the definition that the United States government uses. So you may hear more about intimate partner violence. Just realize that a lot of people that have been in the healthcare field for a while and a lot of law enforcement officers will term it as domestic violence. Now, remember battering? Assault may be a verbal threat, whereas battery is physical. Chronic continuing violence, it can be psychological, because you can batter someone's ego so much that they feel, as we describe on our unit, hopeless, helpless, or worthless. Okay? It often occurs in same-sex relationships as well, One of the things that we are seeing is that the incidence of intimate partner violence is dramatically increasing in the LGBT populations. So just because that person has a same-sex relationship, don't feel that they cannot be battered or physically abused. Again, socioeconomic status makes no difference. It's just that people in higher socioeconomic levels are better able to cover it up. Okay? So what you will see is that always ask those questions and make sure that that patient is kept safe. Now, one of the things that I know Ms. Ward talked about this summer is that the incidence of abuse drastically increases in pregnant women. 16 to 25% of pregnant women report abuse. One of the things that you will see is that a past history of abuse pre-pregnancy often is that strongest indicator of abuse during pregnancy. And what you often see is that the frequency and quantity of abuse increases during that pregnant period. Basically, what you will see is that if that woman is battered during pregnancy, it's a risk factor for eventual homicide of that female. The other thing you need to realize is that abused pregnant women often do not get prenatal care until the late third trimester. So what is that going to do about the health of that woman and that infant? What types of problems are we going to see as nurses with no prenatal care? Glucose problems, okay. Blood incompatibility with RH factor. Hypertension. Infection. Okay. So if this woman is not coming in until she delivers, we don't know what her GBS status is. That gamma beta strep is. So often what you will find is that they will quickly treat just as if they were positive. Okay? The other thing that you will see is that one of the things that's really scary to me, my daughter is out of the teen years now, but teen dating violence is greatly increasing from what it was previously. They're saying now that between 25 and 33% of adolescents report verbal, physical, emotional, or sexual abuse from a dating partner. Okay? And that's in children under the age of 18. 1 in 11 teenagers report being a victim of physical dating violence each year. And this is the scary part, guys. Boys and girls abuse each other equally. So it is not just males that are doing this dating violence. It's females as well. So what does that say about what we're going to see in the future whenever you're talking about intimate partner violence? It's going to increase, okay? Right now what we're seeing is that 80% of the batterers are male. But I would imagine probably within the next 10 or 15 years, that number is going to go down. Okay? I don't think that's a positive thing. Again, teenagers, but look what happens whenever they get into the college students. Previous partners are responsible for 32% of the violence. Current partners are responsible for 21%. 1 in 5 high school girls are physically or sexually abused, but 1 in 4 female students will experience sexual assault in their college years. So the risk greatly increases. Basically, what you will see: possessiveness, jealousy, and stalking. And we're talking about cyber stalking as well. And I think that we've probably seen a drastic increase in the use of the computer and social media for stalking people. Makes it very easy to do. This is one of the key points. This is a case study, guys. An abusive relationship is all about instilling fear and wanting to have power and control in the relationship. And that doesn't matter if it's teen violence or intimate partner violence. It's power and control are one of the key factors that you have to think about. What we see in a lot of these teenagers, as well as the adult women that are abused, is depression, post-traumatic stress disorder, anxiety disorder, suicidal ideation. And I think you've probably seen that on a lot of, I know we've seen it at LifeWorks. The cycle of violence, just as a review. Okay, we talked about this earlier when we were going over some of the general themes of violence. Typically what you will see is that there is a tension building phase where the abuser is edgy, may have some minor explosions, may be verbally abusive but not physically abusive at that time. What happens is that that victim recognizes that tension and tends to walk on eggs or be very careful, making sure that dinner is on the table, the laundry is done, the kids are quiet, those types of things. So that what happens is that as that tension builds and builds and builds, that tension becomes unbearable and a battering incident occurs. What may happen is that that victim may try to cover up that injury, or they may look for help. One of the things that you will see is that intimate partner violence is one of the most common reasons that women come to the emergency department. After that battering, typically what you will see is what we call the honeymoon phase. The abuser has loving behavior, bringing gifts, doing special things. They may make apologies, they're contrite, they promise to change. And what happens is that often that victim is trusting and hopes for change. And they want to believe that promise. But what again happens is that tension starts to build and this cycle will continue. Okay? So that often what happens is that this violence is perpetuated throughout that relationship. Now when you look at some of the characteristics of that battered partner, these are some of the myths that you will see. That battered partner, well, they don't enjoy it. A lot of people feel that, well, if you didn't enjoy it, you'd leave. But that is not the case. Typically, these people live in terror. They don't initiate the violence, but it may be a small incident that just is a major stressor to that abuser, and that violent action occurs. Typically, if they're aggressive towards the violent mate, it's in self-defense. Okay? Typically, powerlessness, very low self-esteem. Again, those feelings of hopelessness, helplessness, and worthlessness. 93% of women who kill their mates have been battered by them. Any of you ever seen The Burning Bed?
That was a good movie.
It's an excellent movie. Basically, it examines this woman that has been battered in her relationship. And basically, she gets this guy drunk, and then she sets the bed on fire and leaves the house. Well, it goes through the situation of, you know, the trial and the whole 9 yards. But it's an excellent look at the relationships with battered women. But, again, 93% of women that kill their mates are battered by them. Sometimes it's an adequate defense, other times it is not. Battered partner, again, often is subject to extreme and irrational jealousy. Often what you will see is that the batterer or the partner, if this woman works, will call frequently to make sure that that woman is at work, that they're not out with someone else. Or if they work with men in their job site, that they constantly check on them. And typically what happens is that the workplace gets aggravated at it, and often the woman is fired. They live in fear for their life and for their children's lives because of the physical and sexual abuse. This is one of the things that happens that makes this very, very difficult to deal with for these women. Because of the relationship and having to hide that battering, typically they have very few, if any, friends. Or they've been isolated from their family members. So often what you see is a woman without a support system, or a man without a support system. So that what happens is that whenever the battering does occur, they don't have anyone to turn to. They're at very high risk for secret drug and alcohol abuse. To escape their problems is used as a coping mechanism. Again, this woman or man says that if they do the right thing, then the abuse will stop. If they believe that I did something wrong, so he hit me. Typically what you will see is that a large majority of these people contemplate suicide, and a large number do complete. Not as many contemplate homicide, probably less than 1%, but I would imagine that when they do, it's usually in self-defense. Okay? Now, one of the things that I will tell you is that with this recent situation with Ray Rice that's been in the media, with Tom Hardy from the Carolina Panthers, there has been a whole lot more discussion and look at intimate partner violence. If you are interested, and we'll talk about this in just a little bit, the hashtag #WhyIStay is very, very interesting. If you just Google that, basically you will get some of the reasons that these women stayed with their partners. The other thing that another site has done is there's a #WhyIStay, #WhyILeft hashtag. And they're very, very interesting to read through. Now, when we look at some of the nursing diagnoses, probably the one that I would say is probably the best is risk for other directed violence. Typically these women, what you see when they come into the emergency room, chronic fatigue, the casual response to serious pain, because they have been so battered in the past that their pain response is dramatically decreased. Typically what you will see is a lot of STIs, often from their partner being very jealous of them, but the partner is not faithful or to them and may continually bring STIs back. Drug and alcohol abuse, burns and patterns. Again, cigarette burns are one of the things that you often will see with those patterns. 42% of abused women require medical care. 20% of abused men require medical care. Again, a lot of times you will see these folks in either the emergency room or the physician's office or clinics. One of the things that you got to remember is that not only do they have those physical conditions, but they will have serious psychological consequences from this battery. And that must be able to be dealt with. Now, when you look at the batterer, the perpetrator of this violence, whether it be male or female, they typically deny that the abuse occurs, and they shift the responsibility to the partner. Now, Ray Rice does not have that excuse because it's on video. Though I will tell you, she did come at him during the elevator, but that was probably in self-defense. But that's a little bit different situation than most of the cases that you're going to see, because it's not going to be on video. It's going to be a he said, she said, or she said, or he said situation. Emotional abuse. A lot of times what you will see is that belittling, criticizing, insulting, name-calling, and undermining their ego. Typically with that occurs throughout the relationship, and often that emotional abuse is much more severe, gets worse during that tension building phase until the battery does occur. Okay? Again, control by isolation. They track events, track the time, track the mileage on the car, stalking, taking the partner to and from work or school, not giving them a car so that you drop it off, you pick them up. Okay? It again, power and control. Control the money. Control through power, making all the decisions. The other thing you need to remember is that violence is a learned behavior, and it's used to control others. Frequently what you see is that violent partners are brought up in an abusive home. They model what they saw their parents do. They have often a low sense of self or poor impulse control, and a very, very low tolerance for frustration. And I think we've seen that with a lot of our patients that we've seen either on LifeWorks or at the VA with that poor impulse control with anger management. Okay? What you will see is that often men who batter will have no guilt. They lack concern over their aggressiveness. Now, one of the things I will tell you is that that is one of the key things when you're talking about reforming men or women who batter or batterers. If they have no guilt and lack concern over their aggressiveness, they are extremely resistant to treatment. Okay? The Wall Street Journal came out with an article yesterday, and it talked about a program about comprehensive battering treatment. And basically what this article said is that if this man does admit to the violence, or the batterer admits to the violence, and they are truly sorry for it, that if they attend this comprehensive program once a week for 4 months to a year, that 60 to 70% of those abusive men who complete that program will not batter within the next year. Basically, the treatment is small education therapy. It's anger management. It teaches coping skills. It teaches communication skills. It teaches a lot of things that these batterers are lacking. And hopefully what you will see is that they are successful in completing that program, because it has had a lot of success. The statistics that I've seen is that, you know, like I said, 60 to 70% of them do not batter within that next year, and they're looking at other longitudinal studies to see if that effect does persist in 5 years, 10 years, etc. However, what they're usually seeing is that typically whenever you get men that are attending these, there often is a court-reported mandate, and sometimes those are not as successful because they don't recognize the need, because they have no guilt over what they've done. The other thing is that I thought it was very interesting is that they've come out with a new terminology, and they call it an intimate partner terrorist. Intimate partner terrorists basically are obsessed with power and control, terrorizing the partner, erode self-esteem. They wield financial control. They're very jealous, very possessive. And what they said is that these men will never change, or these batterers will never change. Basically, typically what you will see is there's a new terminology called situational couple violence. Basically what you will see in the batterer in that situation has just poor relationship skills and very quick triggers. And typically what you'll find is that the situational couple, the batterers that have participated in situational violence are more likely to be treated and have that treatment to persist. Okay? All right. So why do these women stay? Well, majority of them stay because they have no other means of financial support. To leave that relationship means they leave their home, they leave all of their belongings, they leave everything behind. They often have no support system, again, because of that social isolation, because of the relationship. Typically what you will see is that these people are depressed and have lost the psychological energy necessary to leave. I think we've all seen your patients with depression. How motivated are they to get up out of bed in the morning and take a shower and get dressed? Okay. Self-esteem is very low. They believe that that batterer is powerful and omniscient. So what you see is there are a lot of reasons why these folks stay. Again, Google while I stay. It's very enlightening. A couple of other reasons. They need to stay for the sake of the children. One of the things that often will motivate this person to leave is that the person becomes closer or does start battering children. Okay, they start abusing the children. At that point, the person is more motivated to leave that relationship. Rape can be a part of the abuse, especially if the woman's pregnant, which I found Interesting. They may have been exposed to sexually transmitted diseases or infections or signs of trauma. So those are things you need to think about. Now, one of the things you'll see is that the nurse is not going to take point on this one. It's going to be a collaborative effort. Basically, what you're going to see is that healthcare personnel like physicians, nurses, you're going to see social services, law enforcement or lawyers are involved sometimes because intimate partner violence is not a reportable issue. Okay? If that person is over the age of 18, and under 65, then it does not have to be reported if the woman does not wish to, with the exceptions of 3 things. If a knife, a gun, or if there are life-threatening injuries. Domestic violence shelters basically offer a very good array of services, and that's what CVAN and Rowing Crisis Council are. Okay? They also work with children so that not only is the woman safe, but the woman's children or the man's children are safe. One of the things that you're going to say is ask those questions, and we're going to talk about what those questions are. I think it's on the next slide. Yeah. We want a non-family translator. Again, if that person does not speak English very well or does not understand English, then you want someone that is a neutral party doing that translation. You're going to do an assessment of behavior, their affect, their cognitive ability. Okay, not how smart they are, but how well are they putting things together. Okay, are they alert? Are they oriented? Are they cognizant of what's going on around them? These are the questions to ask. Have you been hit, kicked, punched, or otherwise hurt by someone in the past year? If so, by whom? Do you feel safe in your current relationship? And is there a partner from a previous relationship who is making you feel unsafe now? These questions pretty much are asked of everyone that comes into the emergency department, and should be. Screening is one of the ways that you can detect intimate partner violence. Always ask if the children are also being hurt, and if they are, you need to contact Child Protective Services through the appropriate channels. What are their support systems? We want to assess for suicide potential. Not only do we want to ask those 3 questions, but do you plan to kill yourself or harm others? And if they say yes, that I plan to kill myself, what is that plan? Verbal statements should be documented as much verbatim as possible. What that person that is battered said needs to be documented. Don't paraphrase it, because this chart may become a legal part of a legal document. Okay? So you want to make it as clear and as close to what that person said as absolutely possible. Physical findings are often outlined as part of the forensic process. If photographs are taken, that woman has to give written permission, or that man must give written permission. You need to identify whether the patient is interested in pressing charges, and if they are, usually someone in the emergency department will contact the police. One of the things you need to always remember is that if they're not interested in pressing charges at that time, you need to give them information on how to do that in the future if they change their mind. Okay? Always make sure that they have community resources, whether it's the name of these 2 shelters, battered women advocates, or someone to call. Long-reaching effects, again, children from violent homes are more likely to model the actions they see and carry on that legacy of violence forward. Typically what you will see is that children where intimate partner violence occur, they may also feel responsible for that violence. If I'd been a better boy, then Mama wouldn't have hit Dad. Typically what you'll see is PTSD, alcohol or drug abuse, and even some other things that may occur. When you're looking at nursing diagnosis, these are your higher priorities. Risk for violence, risk for injury, risk for self-directed or other directed violence. Those are the priorities. Those are the ones you're going to address first. What do these 3 all have in common? Safety.
Yeah.
Okay. Number 1 priority is to ensure that that person that has been battered is safe in your emergency department, clinic, or wherever, and that hopefully you can give them the resources to maintain safety when they leave that area. Now, these are some of the other nursing diagnoses that you will see, but of course they are lower priority than your safety needs. How are you going to react? Women that are treating the ED may admit to it, but seldom come for treatment or seldom file charges. Nurses often have very strong reactions when children or women are abused. How many times have you heard, he'd hit me one time, and then I'd take him down, or I'd be out of there? But each situation is unique, and you have to recognize that it's up to that abused partner to make that decision to stay in that battering situation or to leave. You cannot make that decision for that person. And what you have to be very careful about is that you have to accept that decision in a very non-judgmental way. If they decide not to press charges or they decide to go back to that situation, it is your responsibility to say, okay, let me give you some resources. Not to say, I think you're crazy to go back. But you want to give them resources. Now, legal issues. Again, we want to do this documentation as much as possible so that we can make sure that whenever, if this does come to court, that our documentation is a fair representation of what that person said. The difference between required reporting of suspected and actual abuse, remember, between the ages of 18 and 65. It does not have to be reported. For child abuse, under the age of 18, it must be. Over 65, it must be. The exception of that between 18 and 65 is disabled adults. People that are not mentally capable of making their own decision. That is a reportable abuse. Follow whatever your hospital or clinic protocol is about reporting that. Basically, these are some of the things that people that are battered need to think about. You want to move to a room with more than one exit. Make sure that rooms that have potential weapons, like the kitchen with the knives, you stay out of those rooms. Know the quickest route out of the house, out of the school, out of your job, so that you can leave quickly. Sometimes what you want is that if it is a situation where there is an estrangement, meaning that you're not living with the battered partner, or if you do have a close friend, you may want to tell that neighbors about the previous abuse so that if they hear something, they can call the police. You need to have a code word for your kids, family, and friends. And that code word may be that I am in danger and I'm under duress and I need help. It may be I am safe, so that they can recognize that. Typically what you'll see is have a safe place selected in case you have to leave. You don't want to have to leave in the middle of the night and have no clue where you're going. Because remember, you don't have a best friend or a close family because of the social isolation. These are some other things you want to talk to this person that's been battered about. They need to have a bag packed with essential clothes, a prepaid phone card, cell phone, but that bag should be hidden but very quickly available. Legal documents should be included if they're able to get their hands on it. A lot of times what you will see is these may be locked away to prevent this person from leaving. Birth certificates for your children, social security cards, photo ID, any restraining orders, health insurance papers. How much time do you think it would take to replace all these documents? It's a long time. All right? A lot of times what you see is that your photo ID, a lot of times, is your driver's license. If you move to a different state, what do you have to get a driver's license? Social Security card. Well, can you just go and get a Social Security card without photo identification? So a lot of times what happens is these people that escape these situations are in a catch-22. They can't get one set of IDs that they need to get the other set of IDs because they don't have the other IDs that they need to get it. They should try to keep these somewhere very handy, if at all possible. A lot of times what happens is these are locked up for just that reason. It prevents them from leaving. Again, some other nursing diagnoses. These are more long-term with the exception of that risk for other directed violence. Okay? What we hope are these are the outcomes. They want that abusive behavior to end, or the victim to remain safe and free from harm. Our priority as nurses to ensure safety for that battered person and to assess the level of danger and to help that person to develop an escape plan. Or if they don't feel that they are ready to do that, give them resources to do that in the future, okay? One of the things that you will see is that with women, a lot of times what you will see is that they will have caregiver role strain because they have children with them. One of the most common reasons for homelessness in adult women and children right now is intimate partner violence. And I know there are several shelters in Mecklenburg County that do accept children. That is a change. It used to be the homeless shelter would not accept families. Now they are. So what's happening is a lot of these women now are able to take their children and have someplace to go. What we hope is these things happen, that victim remains safe and that abusive behavior ends. But it is going to be a long, long process. Questions about intimate partner violence. One of the things that you'll see, our key role, again, keep that person safe and provide emotional support. It's not received the attention that it needs to address the problem effectively. Even though all 50 states and DC have some form of abuse prevention laws, you know, they are not consistent across the board. Now, Adult Protective Services is a state institution that receives and investigates reports of suspected abuse. However, Adult Protective Services is you're only eligible for that if you're deemed unable to care for themselves independently. Typically what APS does is that if that adult is considered incompetent or they have a disability of some sort, the disability basically would apply for all ages as well as the elderly. But APS basically only cares for those that are unable to care for themselves or have been deemed incompetent. Basically, healthy adults cannot be protected by APS from family exploitation. One of the things you'll also see is that APS laws from state to state will vary as to how involved that they will get. One of the things that you will see is that with the Affordable Health Care Act legislation that was enacted in 2010, that part of that legislation was that they authorized funds to address elder abuse, neglect, and exploitation. Okay? Remember in '65, they developed a commission to look to see if it was a problem. Well, in 2010, they said, well, yeah, it's a problem, but the problem is that Congress has never funded that commission. So basically, it is a non-funded part of that Health Care Act, and there is no national legislation that looks at elder abuse. Now, with North Carolina, elder abuse is a required reporting for all health care workers. Meaning that if you suspect elder abuse when they are under your care, whether it be in the emergency department, in the hospital, nursing home, or wherever, you are required to report. And the people that you report it to are the Department of Social Services. Now, what I would tell you is that what you need to do is follow the protocol in the institution that you're working at. You don't just pick up the phone and dial the ESS. Have them on the speed dial. Basically, as a staff nurse, I would probably report it to the social worker and my manager. Typically, in most hospitals, it is the social worker that does report that abuse. But what I would tell you is document who you told and when you told them. Now, with nursing homes, you don't report to DSS. What you report to, if you suspect that someone in a nursing home or assisted living facility is being abused, then you report to DHSR, the Department of Health Services Regulation. They're the people that hold your licensing for your NA1, okay? So those are the people that if they're institutionalized in a nursing home or assisted living facility or in the hospital, they're being abused by a hospital person, it's required to report them to the HSR, and they will investigate. Characteristics, typically what you will see is that seniors are very vulnerable to abuse and other crimes. I think we've all seen the videos of people snatching purses in the parking lots, a lot of times elderly women, because they typically don't fight that. Now, I've seen some grannies with a cane that can be seriously evil, and good for them. But what you need to worry about is that a lot of times they are victimized because of their frailty. It puts them at greater risk for sexual abuse, and a lot of times whenever it's reported, it's often disbelieved. There was a 14-year-old in the city of Charlotte that raped a 92-year-old woman. And basically it was reported, and it was at first sort of discounted because they thought, you know, this woman has dementia, no 14-year-old is going to come in her house and rape her. But in fact, when they did the sexual assault kit, they found DNA, and it was proved, and he is unfortunately doing time in juvenile detention and will be released whenever he reaches the age of 21. Elder abuse is most common, diagnosed in patients with depression, drug and alcohol abuse, dementia, psychosis, and other psychiatric illnesses. Really staggering statistic is that people that are over the age of 80 are 2 to 3 times more likely to suffer abuse and neglect than those patients or people that are age 65 to 80. Victims are 3 times more likely to die than older adults that are not mistreated. And a lot of times what you see is that physical frailty contributes to that lethality of the violence. Older women are more likely than men to suffer abuse. The majority of your victims are white. The other thing that you will see is, that's not on the slide, but the majority of these people that are abused are living with a relative that is the abuser. When you look at abusers of the elderly, basically the profile is very similar to that with intimate partner violence. That's what IPV stands for. It looks like intimate partner violence or child abuse. However, what you will see is that the elder abuser may not be as cruel or as insensitive. Typically what you'll see is the abuser is a middle-aged child of the victim, and they're financially dependent on the older adult. They're living in mom's house, existing on her Social Security. Caregiver often has mental illness, or may have substance abuse problem, or some type of inability to cope. Basically, one of the things you need to think about is that a lot of times that victim must be removed from the home to stay safe, which I have problems with, because I'm sorry, it was her home. He needs to get out. But what you find is that a lot of times what you will find is that removing from the situation is the way that they stay safe, because they may be badgered into letting that abuser come back into that situation. Again, signs and symptoms are very similar to the victim of intimate partner violence. You may hear it referred to as granny bashing, okay? Some red flags: fear of being alone with the caregiver, obvious malnutrition, what you will see with neglect, bed sores, skin lesion, begging for food, needs medical and or dental care, left unattended for long periods. And this one is sort of a problem. You know, people have to work. If someone's doing a 12-hour shift and caring for grandma as well, that's a lot of times where you will see those bed sores or skin lesions or malnutrition because of the neglect. Okay? It is a form of abuse. Typically what you will see is the victims of elder abuse are passive, withdrawn emotionalists. You may see that concern over finances or missing valuables. A lot of times what you will find is that things become missing from the house that have been sold for drugs or alcohol. Okay? Or their checking account becomes overdrawn. Assessment, basically, you want to do a multidisciplinary. It's not just the nurse, it's not just the physician, but you want social work, you want case managers, you want a multidisciplinary approach. Now, one of the things that they've come up with is some elder assessment instruments for use in the clinical setting, and it's a screening tool that looks at the potential or if they have experienced abuse or neglect. Typically what you want to do, and this is something that this is a KDOD for all of these victims of abuse, is to interview the client and suspected abusers separately. Okay? A lot of times what you will find is the abuser seems to be very attentive and will not leave their side. Can you step out of the room for just a few minutes? I need to ask some questions. No. Well, then what do? Do you call security? No. Basically, you send them for an x-ray and you interview them in x-ray. You can get around that just a little bit. If they can, basically, if they go with them to x-ray, you can't come in the room because radiation to your gonads. And then you interview them while you're setting up for the x-ray. Okay? But they must be interviewed separately. Because am I going to say in front of my suspected abuser, he hit me? Because what's going to happen when I go home?
Get it again.
I'm going to get it again. Maintain that non-judgmental attitude, and this is going to be one of the hardest things that you're going to have to do. It's extremely difficult, but you don't judge. It's one of those things like Ms. Rummel was talking about, watch your facial expression, watch your body language. Some of the nursing diagnoses that you will see for those abused older adults: risk for injury, acute or chronic pain, fear, anxiety, and then these two: risk for self-directed violence or risk for other directed violence. Okay? Two areas that you can basically particularly see is that neglect and financial exploitation. There's a new nursing diagnosis out there. It's called adult failure to thrive. So what you often see is that that failure to thrive may be due to that neglect. So consider that as one of your nursing diagnoses for these clients. Questions about elder abuse? All right, let's go to the opposite end of the spectrum, with child abuse. The biggest myth is that the dangers to children come from strangers. In most cases, the perpetrator is someone the parent or child knows and is trusted by the child and family. 80% of child abuse is by a parent or step-parent. The other 20%, about 11%, comes from siblings. So what does that leave? About 9%? That 9% is sort of subdivided by caregivers, like babysitters, or sometimes by strangers, but it's extremely rare. Probably less, about 3%. Characteristics of abusive parents. And I'm going to say parents because, 80% is a pretty staggering statistic. These are some of the things that you'll see. History of violence, neglect, emotional deprivation as a child. Few friends or little or no involvement in social activities. They may be involved in a crisis situation, unemployment, divorce, or financial difficulties. What do all of these do that contribute to the abuse of a child? High stress. Okay. This is a biggie. Unrealistic expectations of a child. That's why we developed that period of purple crying. So that parents that are first-time parents, young teenaged parents, will know what the expectations of a baby are. They don't know all that growth and development that we have pounded into your heads. Drives me crazy that you have to have a license and take a test to drive in the state. But to be a parent takes no education. Because what would happen is that if they had more realistic expectations of what a child could do, then I hope that the amount of children that are killed under the age of 1 would dramatically decrease. So that is one of the roles that we can do as nurses. Make sure, whether you work in OB, whether you work in peds, whether you work in the clinics, make sure that they have realistic expectations of what this child is able to do. Harsh punishment. Spanking. There's a difference between a spanking and a beating. Okay? It is still legal to spank in the state of North Carolina, and in fact it is legal in a lot of school districts. But there is a difference between spanking a child and beating a child with a stick. I used to have to go pick my own switches. And do you want one of the little whippy ones, or do you want one that's not going to bend too much? You want one that... Well, and the thing is that I used to have to do that until one time I was reaching for a switch and got snake bit, and then I no longer had to do switches. So remember that if your child gets snake bit, they get a pass.
Probably scared you to death.
Yeah, then you get beat with a snake. All right, so some other characteristics. They look to the child for satisfaction for the needs of love and support. They may blame the child for his or her troubles. Lack of effective parenting skills. History of drug or alcohol abuse, and they feel like they have little or no control over their own life. One of the things that you will see, especially with the very youngest children, that low tolerance for frustration and very poor impulse control associated with those unrealistic expectations. That's why we see that child abuse is the #1 killer of children under the age of 1. And one of the things that you'll find is that under the age of 1, the two things that make them more likely to be abused are colic. Anyone had a colicky child? How frustrated were you? Very. But if you have that poor impulse control, they're more likely to be abused. The other thing that makes that child more likely to be abused under the age of 1 is either a disability or prematurity. Okay. Common types of neglect. Typically what you will see are abuse. Neglect is probably the biggest, 68%. Physical injury, 16%. Sexual abuse, about 9%. Emotional, about 7%. Characteristics, typically what you'll see, 51.5, just slightly over the half mark, are female. And the majority of them are younger. Sexual abuse is uncommon in infants, but typically peaks pre-pubescent age. So I have seen 3 cases in the last 3 months where the sexually abused child was under the age of 1. That involved penetration.
That's right. That's right.
All right. Let me go on with that one, because I'm not going to comment. I may agree, but I'm not going to comment. Basically, what you're going to see is that with physical neglect, again, this is the highest level of the abuse categories. That's deliberate withholding or failure to provide necessary and available resources. And that is one of the keys with neglect, okay? Deliberate withholding. or failure to provide necessary and available resources. It is not deemed neglect if you do not have the resources available, if it is not deliberate. Okay? Failure to provide for basic needs, supervision appropriate for a child's age. Remember, you do not leave your 6 children with a 9-year-old and the house catches on fire. Unfortunately, that does occur. Adequate nutrition and hydration, shelter, appropriate health care. This is, again, the most common type of abuse.
What is the age that you can leave a child alone?
There is no law that I have found. It depends on the maturity of the child. It also depends on your situation, okay? Leaving a 10-year-old at home in a house with an alarm system is different than leaving a 10-year-old home in a crime-ridden neighborhood. It depends on the situation. But typically what you will see is that alone is different than leaving them, a 10-year-old in charge of a younger child. Okay. Some of your indicators of neglect that may be that these children are frequently absent from school because they don't have transportation or the way to get to school. Either begs or steals food or money. You may see a lack of medical or dental care, immunization, or they don't have glasses that are necessary. They're consistently dirty or have severe body odor. They lack sufficient clothing for the weather. They don't have a coat. They may not have shoes that are appropriate. My daughter and I have what we call the rainbow rule. It has to be 65 degrees for her to wear her rainbows. Of course, now she's in college, she probably wears them when it's snowing on the ground, but you know, you just make sure that you've got the appropriate clothing for the weather. The children may state that there's no one at home to care for them. So those are some of the indicators that would give you suspicion of physical neglect. Now, this is one that I found very interesting. Overindulgence is also a form of neglect, though I doubt seriously that you will have any child complain about it. Basically, what you will see is that because our financial resources have increased and our family size has decreased, a lot of times there's more available money for those individual children. So they may have an Xbox, they may have a Game Boy, they may have all sorts of things, a TV in their room. So overindulgence is a form of neglect as well. Typically what you will see is that it causes social impairment, emotional stunning, particularly empathy for those of others. What you find is that it causes physical activity problems like obesity and can lead to other health problems. One of the things that you will see is that it's all about me is one of the things that you see with that overindulgence. And that's one of the things that you see that decreases empathy for others, is because they always have what they wanted, they needed, If something breaks, you buy them a replacement. So that a lot of times they don't have that empathetic, sympathetic relationships with others. Okay? Hang on 1 second. Let me see what this overindulgence. Emotional abuse basically is another form, shaming, ridiculing, embarrassing, or insulting the child. This can also include destruction of the child's property. I don't know if you've seen those video clips. Last year there's this guy that got so upset about his daughter's Facebook account, he shot her computer. And then there was a just recent one. If you have not seen it, it's sort of pitiful, funny but pitiful. Where this guy's son,
The video
the
games.
Xbox games, basically he took all of the games out of the containers and put them in the yard and ran over them with one of the Toro lawnmowers. Basically, get out of the basement and get a job type deal. Depending on which way you're viewing that, that could be considered emotional abuse. It can also just be a kick to get him out and doing something that he needs to do. A lot of times you see emotional abuse, but a lot of times you see emotional neglect. And if you think about the patients that you have seen in psych mental health, a lot of times they're so wrapped up in their own problems that they have problems dealing with their own situation. How emotionally available are they to their children? So a lot of times what you will see is that emotional neglect because they are emotionally unavailable. Okay? So what you would see is that it can be just as devastating as physical abuse. Now, with physical abuse, this is the one that we see a lot in hospital emergency departments and sometimes on the pediatric units. They come in because of the physical injuries that they have experienced. Again, suspected child abuse is a mandated reporting by healthcare providers. Typically, some of the things that you will see, immersing the child or a body part in scalding water. Typically what you see with that is that you will see what we call stocking type injuries. Basically, the injury occurs to where they have dipped that child in the water. Shaking the child violently, like with child abuse with shaken baby syndrome. Tying the child to an object, like to the porch swing, or you know, a lot of people have the theories. You know, I've seen the little child leashes. Have you seen those? Yes. All right, I have not so much trouble with those as I would be to that poor child that was in near Monroe, where he was tied to the porch with that dead chicken hanging around his neck. And his mom was the DSS supervisor. That was also, and his dad was a nurse. So you see all types. Throwing children against the wall, window, or stairs, choking, gagging, fracturing. Remember, I talked about those spiral fractures from twisting, or that jerk, that maul arm that you see with that brachial plexus avulsion. Deliberate overdose or withholding meds. Now, deliberate overdose. Why would someone overdose their child? Get them to sleep. Okay? Benadryl. I've seen it used many a time on car trips, so that they can ride to the beach without the child waking up. Well, unfortunately, what happened is that they overdosed the child, and when they got to the beach, the child would not wake up. Withholding medication. And we are going to talk a little bit about a syndrome called Munchausen by proxy. Basically, what you will see is that a lot of times with pathology, they withhold the medication, the child gets sicker, the parent gets more attention. So you may see that as a deliberate thing because the parent seeks that empathy and sympathy.
Hyde. The mile arm, you said when they pull them, is that the same as when you dislocate the elbows or whatever?
No.
This one's right here, right?
Yeah. Maul arm is basically you take an arm and jerk, and what happens is that these nerves in that brachial plexus get stretched or pulled, and typically what happens is that because of that brachial plexus, they call it an avulsion, that arm loses feeling. So what you will see is that that arm will just sort of swing and it not be functional because they're not able to move because of the innervations. Just an idea, this is a girl that's been whipped with an electrical cord. And you can tell that it's an electrical cord that's looped because, see, you can see the loop right there. Okay? You notice that the arms and the legs are pretty much free because those show. This does not. Other examples, cigarette burns are fairly common. Taking a lit cigarette and burning that child. You typically see those small circumscribed injuries here. Basically, this one are pinches. This one is that stocking foot. It's a burn from scalding water. Let me show you to see if you can see it a little bit better. But you can see that the skin has come off because of the blistering of that injury. This is a fracture in an infant. Okay, you can see here. 50-day-old. Also had abusive head injuries. If you see leg fractures in an infant that is not walking, it is always should raise your instinct about suspecting abuse. Because typically you do not see fractures in non-walking children. Now, one of the other things that you might see with children is typically multiple fractures in various stages of healing. Okay? Not only do you see arm fractures, leg fractures, but rib fractures from either hits, slaps, or actually squeezing that child and shaking them.
There's one now, he squeezed it and fractured like 29 ribs.
Yeah.
And like,
so one of the things that you should have a very high incidence of suspicion of abuse is multiple fractures in various stages of healing. Now, that's not to say that there are not situations where, like children that have this brittle bone disease, that will have bones that break with just a touch. But often what you'll find is that that may be a medical diagnosis that they have to see and prove before those parents are cleared for abuse charges.
I know somebody that happened to recently here in Salisbury. They took their children away from
Yeah.
them. She had to go to Ohio because he has a lot of medical problems. He had to see specialists, and it took them over 2 months. They took all of their children away.
Yeah. It can be very devastating to the family. But if it had not been that, it probably would have been, you know, better for them to get out of that situation. But it can be very, very devastating. One of the things you need to remember is that children who have been abused are more likely to abuse others in the future. Because, again, it can be a learned behavior. Some of the things that you'll see: inappropriate responses to pain, and that can be one of two ways. Either they become hysterical with small injuries, or even with large injuries, there's no response. So one of way or the other. Broken loose teeth may be one of the things that you see. We see a lot of human bite marks as well. And yes, like they do on CSI, you can do castings of those and sort of prove who did the biting. All right, let's look at this and then we're going to take a break. Head injuries, skull fractures, bruises, welts. This is one of the things that you will see, is that that child may protect that abuser because they fear further punishment. A lot of times you may have asks and they'll say, no one hurt me. But a lot of times you have to develop trust with that child in order to get the full story. They can be withdrawn and avoid all physical contact with adults because they feel that every adult is going to harm them. Again, what you'll find is rope burns from being tied, or that stocking type injury from your scald or immersion in hot liquids. All right, let's hold off here. Let's take another break. A faculty member from another part of the state. She was moving here to be near friends, and she and her uncle were packing up her house. Her ex drove by her house, saw that she was packing, came into the house, shot and killed her, shot the 10-year-old. The 10-year-old did survive, and then shot himself. So it's one of those things that it is an extremely dangerous time whenever a lot of these people leave that relationship. The other thing I will just sort of put out there is that another of my friends, as part of her research project for her doctorate of nursing practice, looked at nursing students that had been victims of intimate partner violence and looked at the terminal semester, that last semester of nursing school, and then looked at the 3 to 6 weeks after that relationship, after graduation. What she did for her study is that she set up dummy email accounts, Gmail accounts, because she did not want this survey going to their home email or to their school email because of privacy issues and confidentiality. What she found, very interesting, is that even though these nursing students, whether they be men or women, had been battered sometimes throughout their school program, the incidence and the intensity of the violence increased during that last semester prior to graduation, and it increased after graduation. Why do you think that would be?
Because they knew they had the ability to leave.
Because they knew that they had the ability to leave and support themselves or their children. Okay? So that's one of the things that I will just let you know, because that will happen with any person that actually is getting a degree and may have the opportunity to earn money on their own. Okay? Just FYI. All right, let's talk about sexual violence. I don't want to get all the great topics. We're talking about sexual violence. One of the things that I want to talk about is the terms survivor and victim. I mean, I don't like the word victim because it tends to victimize that person, okay? Basically, victim as the terminology is used to identify that person who's experienced that sexual assault, but can eventually become a survivor with time, intervention, and counseling. A sexual assault survivor is someone that has experienced an assault in their life and has worked through many of the issues and is going forward. It says in her life, but I will tell you, you should change that to their life, because the statistics are really frightening whenever you look at all of them. Sexual violence, basically, two key terms: who did not consent or who are unable to consent or refuse to allow the act. It's either completed non-consensual sexual act, attempted sexual act but not completed, abusive sexual content, and non-contact sexual abuse. Okay? Some of this may be verbal, abusive sexual contact, maybe groping, attempted but not completed, attempted rape but no penetration, and then this would be completed non-consensual sex is the legal act of rape. And rape is a legal term. Okay, one of the things that you'll see that we'll use in either nursing or the medical profession is sexual assault, because it's a catch-all phrase that it may not be a rape. Okay, because what you will find is that that legal definition are going to vary from state to state. We're starting to see more date rape. Basically, in the case of the date rape, the victim agreed to spend the time, but what you need to recognize is that date rape is still rape. It's a criminal act, long-term medical, psychological, legal, and social problems for that victim or survivor. Basically, this is one of the things you need to remember. Reporting of sexual assault is not mandated unless it involves the abuse of a minor or an older adult or a disabled person. Yes?
Did you hear about the nail polish that for NC State?
Yes.
They,
Yeah, and we'll talk a little bit about those date rape drugs. What she's talking about is there are 4 students at NC State that have developed this nail polish that if you wear it and you stick it in your drink, it will detect the presence of date rape drugs. It changes colors, okay, so that you can see that, you know, okay. Well, they're getting a lot of flack about it because, you know, you think it was great. It is great, but unfortunately what happens is that as soon as the formula for those drugs might change, it may give that person a false sense of security. And one of the things that we'll talk about is that the most commonly abused date rape drug is just plain old alcohol. That you don't have to use like GHB or rubies or anything like that. But it is one of those things that has been developed, and I'm hoping that they will continually develop something like that, because, you know, it would be a nice thing to know if someone slips something in your drink. Again, unless it's the abuse of a minor, an older adult, or a disabled adult, it's up to the survivor of that assault to make the decision to report the crime. Again, it's the nurse's role to offer support, information, and usually if they give permission, securing that forensic evidence that's necessary. But it's not, hopefully not just some random nurse in the emergency department. Typically what you will see is that large major medical centers have developed a program here in North Carolina. It's called SANE, S-A-N-E, Sexual Assault Nurse Examiners. And that's the qualified person. Basically what you'll see is that statistics are always approximate. Usually what you will see is that sexual assault is committed against men, against women. However, sexual assault can be committed by women against men or between persons of the same gender. The majority of perpetrators are men. However, if you look on the sex registry list now, you will see a large number of female faces. I don't know if you remember or heard me the other day in class, there are 2 cases right now where 2 young men, I think they're age 18 now, were sexually abused by a woman at the age of 13 and 14. A child resulted from that sexual assault. Those men at the age of 18 are now being sued by DSS for child support, which makes no sense whatsoever. But that, unfortunately, is the case right now. One of the states says that it doesn't matter that he was the victim of the sexual assault. The other said, oh, we didn't know about that, we'll have to look into that. But still send a check.
They didn't report it at that time.
Yeah, they didn't report it.
So if they would have reported it, they wouldn't.
Well, no, they said, one state says it doesn't matter. So I think what we will probably see is some legal wrangling around those 2 cases, and there will be a lot of laws that will be changed for that, because of that reason. I hope, because that's ridiculous. One of the things that you'll see is that gay men are more likely victims of sexual assault than heterosexual men. One of the things we're starting to see is that rape of men in the military and in prisons are probably where you have the greatest percentage of male rapes. But it happens pretty much anyway. One of the things that you will see is that a lot of time when a male is a victim of rape, it is often not reported. And in fact, they say that probably less than 1% of male rapes are reported. Even if they're reported, often they're categorized as assaults and not sexual crimes. So the statistics get a little hairy there when you start looking at that. One of the things you need to remember is that more than 50% of gay men and lesbians have reported at least one incidence of coercion by a same-sex partner. So it's not just a male-female problem. There is a problem with sexual assault throughout the LGBT community as well as in the heterosexual community. With sexual violence, again, these are frightening statistics when we look at high school and young adults. 20 to 25% of college women will experience an attempted or completed rape by the end of their college years. 90% will know their attackers. 90%. Which means it's either date rape or acquaintance rape. Ages 16 to 19 have the highest rate of sexual assault. And typically what you'll see is alcohol and drugs. Alcohol and drugs are often involved in gang rape. And by definition, gang rape is 2 or more perpetrators. Now, when you're talking about date rape, usually it's by a new acquaintance. Typically, it's less physical violence because often what you'll see is that it involves these date rape drugs. The 3 that are most common are GHB, or gamma-hydroxybutyric acid. It affects the central nervous system. You may hear it referred to as liquid ecstasy, salty water, scoop, or homeboy. Typically, what you'll see is GHB causes a euphoria and sedative effects. Well, where do you get it? Well, it's legal in the United States as a treatment for narcolepsy. Typically, what you'll see is that GHB has an onset of about 5 to 20 minutes. The duration is going to be dose-related. If someone overdoses on GHB, typically what you'll see is respiratory depression. It can be detected in the urine and blood for up to 12 hours after dosing. Usually 12. Rohypnol, or roofies, it's called a forget drug. It's a very potent benzodiazepine. It probably is about 10 times the strength of Valium or diazepam. It's illegal in the United States. Typically with Rohypnol, usually you see effects in 10 to 30 minutes. It will last 2 to 12 hours. 2 to 12. Protect your airway. Protect your airway if someone comes in that's been breathing. Rohypnol can be detected up to 72 hours in the urine. Ketamine is an anesthetic that's frequently used in veterinary practice. I've also seen it used in kids for anesthesia. Vitamin K, or Special K, you may hear it termed that. Typically, it is a hallucinogen, very similar to PCP. Strong, vivid dreams and nightmares from this drug. Onset's about 20 minutes, and it lasts up to about an hour. Though typically what you'll see is that people experience amnesia effects for much longer, up to 24 hours in some cases. It is a general anesthetic. so you want to make sure that your airway is protected. I think the drug that, the nail polish, basically was looking at retinol. That's what it detected. It did not detect for the other two. So, those are one of the things that you'll see, that basically rapes are related to date rape. They're increasing. Majority of the women don't report because a lot of them don't remember. They don't want to get their friend or date in trouble, or they don't want others to know. CeeLo Green just got into a lot of trouble on Twitter just recently. I don't know if you realize that he slipped GHB into someone's drink, and there's a case pending against him for sexual assault. One of the things that he tweeted the other day is that it's not rape if they don't remember.
Oh, wow.
CeeLo Green. So, he very quickly rescinded that tweet, but, you know, with that case pending in front with him, he's probably going to be convicted of that. So we'll see.
Did you say like they were the last 1 hour?
Vitamin K, usually about 30 to 60 minutes. Again, date rape drugs. One of the things that if this woman feels that she was date raped with these drugs, they do need to get into the emergency room as quickly as possible. Because if those drugs clear in 12 hours, you know, it may have already been cleared from the body, so that you want to make sure that you have that evidence. But again, the most common drug used to facilitate the crime of rape is still alcohol. And that is one thing that we need to teach our young children, teenagers, and young adults, is that alcohol, because of the inhibition removal that happens, that is one of the things that can get you into trouble very, very quickly. Now, marital rape, it used to be, in fact, until 1993, it used to be that if you were married, it could not be considered the act of rape. That law changed in 1993. It is one of the most prevalent and underreported rapes. These people are less likely to report or seek professional help. Men can be raped by women. Erection can be evinced through stimulation. So that, you know, marital rape can go either way. When you're talking about people that are vulnerable to sexual assaults, women have a higher vulnerability, but both genders are more vulnerable if they're handicapped or disabled. Again, when you look at statistics, those aged 16 to 19 have the higher year of sexual victimization. Children are most vulnerable between ages 8 and 12. Remember, that's that prepubescent age. Typically with older adults, intimate partner violence is most perpetrated by relatives, caregivers, and healthcare providers. Healthcare providers. We see it a lot in assisted living and long-term care facilities. Basically, if you have had a history of sexual violence, women are more likely to be raped before the age of 18. Women that are raped before the age of 18 are 2 to 3 times more likely to be sexually assaulted as adults. And it's often due to the relationships that are perpetuated. High-risk sexual behaviors. Often what we will see is that maybe as a result of childhood sexual abuse. Native Americans have a 1 in 3 chance of being raped. Just a fact. If you look at some of these factors with the perpetrators, well, it's sort of the same thing that we looked at when we were talking about violence, whether it be child abuse or be partner abuse or elder abuse. Typically what you will see is some alterations in neurotransmitters. Looking at dopamine, norepinephrine, acetylcholine, and GABA. And they're thinking that with those neurotransmitter alterations, that places that person at a higher risk to perpetuate this violence and sexual assault. Psychosocial factors, antisocial personality disorder is one of the most prevalent things that we see as perpetrators of sexual assault. But what's really interesting is that most of the people that assault others sexually have a history of sexual assault as children. Again, it's a learned behavior. Perpetrators of sexual assault typically sexually aggressive or has associated with sexually aggressive or delinquent peers. Like your mama said, you're running around with the wrong group. A preference for impersonal sex, meaning that they don't care who it is. I didn't know what her name was. Hostility towards women. Witness to family violence, maybe a member of a gang, or belong to a societal group that turns its back on sexual assault. Now, whenever a person that has been sexually assaulted comes into our emergency room or to our clinic, one of the things that we need to remember is they have the right to have a rape crisis advocate with them, have family or friends present, have their own personal physician notified if they feel more comfortable with that person. They need privacy during assessment and treatment. Those of you that work in the ED, where is your triage room or area?
When you first come in.
It's in the front, but it's a little blocked off. Some hospitals have it as a desk at the very front. All right? So how willing do you think that these victims of a sexual assault are going to be to come in and say, I was raped? Say that again. Okay? You don't want to do that in front of people. They need that privacy. They need their confidentiality maintained. Basically, what you want to get is once they are back in that emergency department in a private area, you want to get detailed explanation and consent for treatment. Okay? Anytime someone comes in that has been sexually assaulted, you have to get informed consent for collection of evidence for the court if they wish to press charges. Now, what is probably the better thing to do is to get that consent, collect that evidence, and then the woman or the man has the ability to say, I don't want to go any further with it. And they have that right. But it's better if they are sort of waffling to get the evidence and then they can make their decision. One of the things that you'll see is a sexual assault nurse examiner, SANE nurses. A lot of our hospitals are starting to have this program in their emergency department. Only about 10% of the hospitals in the United States have a comprehensive sexual assault program. Though here in North Carolina, we have a large number of sexual assault nurse examiners because there is a program that they can go through the AHEC system. And if you're in a work in the emergency department, then this may be a role that you would want to consider. It's a number of courses. You go through a preceptorship where you're mentored in how to collect that evidence, how to look at pictures, how to be respectful of that person whenever you are collecting that evidence. Because one of the things you do not want to do is to further victimize that person. All right, I need all your clothes in a bag. Put your underwear in here too. What message is that sending to that person? That you're a bother? Why did you even come in here? So you need to be very aware of the way that this evidence is collected. And you can see that some of the documentation that they'll do. And if pictures are consented, then they will take those pictures and hold for law enforcement. KDOD, guys, this person should not be left alone, and they should have a private area. You need to psychologically as well as physically support this person through their exam. You want to have documentation of current history and a very thorough physical exam. And unfortunately, what that typically means is that they will have to do a vaginal exam with swabs. So it is, again, a very intrusive exam on top of what this person has already experienced. Both vaginal, if it's a woman, and anal swabs, and anal swabs if it's a man. They may also do oral swabs. Any bite marks or saliva are collected so that there are pictures of those bite marks. Those of you that have watched CSI know that you can match the bite mark to the bruise. Institutional protocol is followed. Rape kits are used and collected for evidence. This is one of the things that I think that is a major problem in the U.S., North Carolina in particular. I think that what we're starting to see is that rape kits are often collected, but they sit sometimes for years. Such that if they have this evidence, it may be degraded to the point where it's not being able to be used for prosecution, or it may be that if they were to process those kits, they will find that there is a one repeat serial rapist, and they would be able to prosecute that person for more than one crime at a time. Basically, other things that you're going to see is that urine collection for date rape drugs. The other thing that you will see is that they often will comb pubic hairs to ensure that if there are pubic hairs that have been left by the person that assaulted this person, collected for evidence. One of the things that you'll see is that chain of custody is followed until the incident's turned over to the authorities, so that we don't want to break that chain of evidence, because if that does happen, then it decreases the usability of that evidence in the court of law. Okay? Treatment and documentation needs to be accurately look at some of these words. Instead of using alleged sexual assault, we wanted reported sexual assault. Instead of treatment refused, treatment declined. Instead of intercourse, when we're talking about vaginal penetration, that's what we want to say, or anal penetration. No acute distress, what does that mean? Doesn't really mean anything, does it? What we want to do is describe their behavior. Remember that they may not look like they're in acute distress, but you don't know what's going on in that head. Okay, we talked about those. Physical injury, vagina or rectum may be painful and swollen because of the amount of violence. There may be vaginal or rectal wall tearing. Throat may be traumatized whenever it's forced oral genital assault. One of the things that you need to be very aware of is that whenever there's tearing of the vaginal or rectal wall, that person has not only been sexually assaulted, but they probably now have been exposed to HIV. One of the things that we see with sexual violence against gay men is that there is a greater increase in rectal wall tearing because of the amount of violence, and those men are more likely to become HIV positive. "25% of people that are sexually assaulted have evidence of impairment 1 year post-rape. Typically, you will see 3 stages that these victims will go through as they become survivors. The immediate responses occurs immediately after the rape and may continue for the number of weeks. Typically, during this phase, you will see numbness. You will see a very flat affect. You may see just sort of disconnected with the rest of the world. During that reorganizational phase, you will see some symptoms of trauma continue to occur, and hopefully they're seeking help with support groups or counseling. If not, then often these victims develop PTSD or anxiety disorders. Whenever they enter the recovery phase, that's whenever we call them survivor of a sexual assault. Immediately, this is what you may see. Either severe anxiety or calmness, flat affect, depression, feelings of helplessness and vulnerability. This is one of the reasons we do not want these people left alone. They're emotionally vulnerable during this period of time and need someone for support. Rape trauma syndrome is a diagnosis that very closely mimics PTSD. And some of the treatments are going to be very, very similar to what you see with a lot of your vets or other people with PTSD. Acute confusion, impaired memory may be due to that either the alcohol or those date rape drugs. It may be because of the severe trauma that these victims experience. What we hope is these outcomes. We want them to receive treatment and follow-up care. Develop that safety plan. Again, very similar to what we saw with intimate partner violence. One of the things you need to remember is that 5% of rapes result in pregnancy. You, as the nurse and the healthcare provider, will probably offer contraceptive. But a lot of times you will see that women will refuse it based on their religious beliefs. Plan B is a treatment that you will see. It is available over the counter. So even women that don't come to the emergency room, or women that have not used contraceptive or have had unprotected sex in some way, can get it. Basically what you'll see is that it has to be taken within 72 hours of the sexual contact. Typically what you'll find is that they will have some side effects that the woman needs to know about. It is a medication that's hormonal. Nausea and vomiting, abdominal pain, fatigue, headache, diarrhea, dizziness, and breast tenderness. It's sort of like a super surge that you get premenstrual type thing. So what you find is that with that Plan B, the woman needs to know about that side effects. It is to prevent the fertilization of that ovum by the sperm. It will not cause abortion once that has been fertilized, okay? The other thing, of course, is that you're going to offer prophylactic treatment for STDs and HIV. Typically what you will see is that women or men that are raped, basically what we want to do is to get a baseline HIV. We will test again at 1 month, 6 months, and 1 year. The STDs that we typically treat for are gonorrhea, chlamydia, and trichomonas, because those are the most common. And unfortunately, we're starting to see more and more syphilis as well. Just as an FYI, North Carolina is the penicillin-resistant gonorrhea capital of the world. So definitely want to make sure that people are treated for such. If they have had violence or a beating along with the sexual assault, with any abrasions, definitely tetanus injection is necessary if they've had 5 years since that last immunization. Now, other pharmacology, typically what we want to do if we have someone in that very high anxiety state, giving them a benzodiazepine like Ativan may be one of those things to help with their acute anxiety and agitation, but it is very, very short term. You do not want to send these people out with that benzo. Basically what you will see is that your SSRIs are used to help treat some of those symptoms of PTSD. And you're going to want to evaluate for hyperarousal, agitation, insomnia, depression, and panic attacks, which are all signs that these people may be reliving that trauma, having flashbacks, nightmares, and reliving that sexual assault. One of the things that is very, very key with helping these people go from victims to survivors is that you give them choices, okay? If they are in charge of their treatment, they survive much better, more psychologically and emotionally intact. If you do everything for them, it basically perpetuates that victimization. So So making sure that they are in control of the decisions that are made is very, very important. One of the things that they should all have within 24 to 48 hours, all victims of sexual assault should have a follow-up with crisis counseling. And typically what you'll see is that they will, on their discharge instructions, you will receive a call from this number so that they know that that's the number of the crisis counselor. Or if they want to call them prior to that 24 to 48 hours, it's probably better. But follow-up is key. Allowing them to be in control helps them move through that process. The other thing, of course, is support groups or group therapy. It helps with determining their own distress and taking charge of their recovery. Some people don't feel comfortable with group therapy. Some people feel very comfortable. So that will depend on the person. Long term, again, what you may see is PTSD. Secondary phobic reactions to people, objects, or situations if they're in similar situations as to when their sexual assault occurred. Working with these people long term, what we're trying to do is to help decrease the signs of PTSD. One of the things that you will see is that as a process, because of the sexual assault, they may have difficulty with intimate relationships with other people. And it may take them a long time to develop those intimate relationships. But one of the things you need to remember is that sexual assault is a crime of violence. It is not a crime of sex. Okay? Unfortunately, sex is the way that the violence is perpetrated. And it helps if your victim is able to understand that. It was violence and control and power, but unfortunately, that sexual assault was the way that it was conveyed. Just going to sort of skim over this because I know Ms. Rummel is going to talk to you about PTSD in relationship to some of your veterans that experience it. But remember, PTSD occurs with any emotionally upsetting thing. An automobile accident, sexual violence, or witnessing a murder. Those types of things can cause PTSD. Typically what you will see are these types of symptoms, and we treat them a lot of times with SSRIs. Crisis counseling, we've talked about. Basically, again, if those that are involved with intimate partner violence, we want to make an escape plan for these people so that they should have a list of safe houses available or know how to contact those persons, because sometimes it's not safe to have that list in the house. Now, therapy for rapists. Basically, one of the things that you've got to realize is that a change in behavior and change in thinking needs to be undertaken for them to affect change. Unfortunately, most rapists don't acknowledge the need for that change. As opposed to battery, there's been no single method or treatment that has been found to be totally effective. Of course, a lot of these people do experience long jail terms. However, it will depend on the state as to how long that term may be. A lot of times what you'll find is that they are released and perpetuate that crime again. The other thing, of course, if there have been some sort of research, I want to say in the late 70s, early 80s, about chemical castration. Yeah, all the guys' heads just jerked up. Basically, what they were doing is giving these men high doses of estrogen so that they were not able to maintain erections. However, that's sort of gone out of favor, and that's not one of the things that they do anymore. But unfortunately, treatment for people that perpetrate sexual violence has been very, very unsuccessful. And we're hoping that, you know, with future research that they can come up with something. But I think that one of the things that will help with treatment is for us as a society to recognize that what it is a crime of violence. It is not something that needs to be hidden and that people that have been victimized need to be ashamed of. So, just my 2 cents. All right, y'all want to take another break? And then what we'll do is any questions about the culture topic that I've heard? Any questions?
Do we need to know each one of those in the treatments?
The specific cultural syndromes. You may see some of the ones that, you know, are more, that I talked about more. One of the things you need to remember about these cultural syndromes is that the reason that they're in that DSM-5 is that these specific cultures display anxiety, display depression, display mental illness of some type in more acceptable manners or somatic ways, okay? It's just like in our culture with depression, a lot of people, what you'll find is they will complain of, I'm tired, I'm fatigued, I have no energy, I have headaches, those types of things, instead of saying I'm sad or I'm depressed. So think of it more as a outward expression of whether it's anxiety, depression, etc., etc. You know, what you might see in those populations is that's how they present to the emergency department or the physician's office, instead of saying, I have depression, I feel like killing myself. They come in and say that I have this more culturally acceptable condition. What questions do you have about any of those cultures?
That's what I was gonna ask, like, is it gonna be that type of, you know, you have this type of patient and, you know, what would you not wanna do for this patient, or what would be offensive?
Well, it may be. I mean, if you look at, when I talked about predominant values, I talked about eye contact and personal space and touch and facial expressions. Even though you don't want to stereotype people, typically what you'll see is that eye contact in some cultures is considered rude or offensive. Whereas we tend to say that if I'm looking at you, I'm expressing interest and making sure that we have that eye contact, and if you look away, then typically that's considered as evasive or not telling the truth or whatever. Whereas in some of the Arabic cultures, it's really intense eye contact, And we in the American culture would consider it rude or offensive because it's so direct that it's like a threat or an assault on our person. Again, with those space considerations, and who do you touch and who do you not touch? You know, in some cultures, one of the things that you'll see is that they will delay discharge teaching until the family member comes into the room, because that family member is considered responsible for their care. And that family member, I'm thinking some male-dominated cultures, that family member is the person that makes the decision whether they're able to take that medication or not, or follow through with that treatment or not. So those are things you need to consider.
I know this is.
Yeah, you know, especially if I mention them in class. I mean, the thing is that you have to be very careful, and one of the things that I mentioned, the specific ones that I mentioned are the ones we see here in Rowan and Cabarrus County, Mecklenburg County. One of the things that we're becoming more as a society is more of a polyglot, meaning there are all sorts of cultures there. And what's happening with that is that we are taking on some aspects of other cultures so that it's not, you know, this person may be Latino, but they're not pure Latino like they would be if they had not been exposed to some other cultures. So it's one of those things that you sort of are aware of, but you sort of have to treat each person as an individual. Just because they're Latino doesn't mean that they follow all of that. And that's typically what you find with, especially second or third generation of that family. Typically what you'll find is that third, especially the third generation, is much more like the American culture than they are their primary heritage culture. So you just need to be aware of it. Treat each person individually, but just be aware that there may be some cultural norms that they may not be comfortable with. Especially, you know, with touch. I mean, it's one of the things that we as nurses do a lot, as, you know, patting their hand or stroking their hand to convey empathy and sympathy, okay? But touch in some cultures is considered an assault, especially between opposite sex, because it's considered a sexual come-on or as a sexual gesture. So you have to be very careful about that. What other things? What does it mean by patriarchal society?
Man is dominant.
The man is dominant, has the control. What about that cult of domesticity? You have to do everything. The sort of superwoman syndrome, okay? What is that going to do if you've got someone that it's defined as woman's work, and that includes child rearing, housework, meals, work, wherever, you know, everything else? Typically what nursing diagnosis do you see? Caregiver role strain, fatigue, anxiety, those types of things. Yeah, psychotic episode, because you're trying to go in 42 days at once. All right, so anything else on those cultures? All right, let's look at that next handout. That's the generic violence one. talking about that detention building, battery, and then that honeymoon phase. I'd review that. So that you're aware. Remember, if you've got someone that comes in with trauma, whether it be due to intimate partner violence or assault, or sexual assault, we always start with our ABCs, guys. Airway, breathing, circulation. Make sure that that person is assessed head to toe to make sure that we are making sure that they're still breathing and heartbeating. Just because they're a victim of violence doesn't mean that we don't do that. Any other questions about that topic? I mean, it was just a general overview to set you up for the next one. All right, what about elder abuse? Reportable or not?
Unless they're,
Unless they're disabled.
And like examples of five different kinds.
Just remember, it's not always physical abuse. Probably the one that we see most often for these folks is financial. Someone gets a hold of their checkbook and controls all their money and diverts it for their own use. Why is violence against elders very difficult to detect sometimes?
they think it's other illness.
The dementia, or they're scared. What are they scared of?
They don't want to leave their home.
They don't want to leave their home. They're afraid that someone's going to stick them in a nursing home. Who do we report elder violence to?
Adult Protective Services. Adult Protective Services.
Adult Protective Services, if they are abused, neglected, exploited, disabled adult. Okay? If they're not, if they're deemed competent, then you're sort of SOL. That the law of the protection of the abused, neglected, or exploited disabled adult law doesn't cover someone that is not either physically abused, physically neglected, or exploited, or disabled. Financial abuse basically would be reported to the police, but one of the things that you have to be very careful about is that you want to make sure that, you have some type of evidence, or they are able to present some type of evidence. Who do we report abuse, elderly abuse in nursing homes to? DHSR. Remember, they're the people that control your NA1 license. And if you've ever looked at your license on DHSR's website, it will say if any type of abuse has ever been reported. They have it on the website. What is the typical elder that's abused look like?
Dirty. Dirty.
Dirty, maybe, if it's due to neglect. What characteristics would you imagine that this person would look like when they hit your emergency room door or clinic door?
Malnutrition.
Malnutrition. Maybe malnutrition.
Keep their eyes averted, kind of
maybe sores.
Fear.
skittish.
What age?
Um,
75. What race? Caucasian,
Female.
female. Okay, what, typically, who is the person that is abusing this elder?
Family member.
Family member or caregiver?
It's Hyde.
Uh-huh.
I want to make sure, so as far as elder abuse and reporting it, so if we're in a facility, we report it to like chain of command, like to the social worker, whoever, then they go on beyond that.
Right.
Okay, but in the nursing home, we directly report to the DHSR.
Well, that depends on your facility, okay? If you're the RN in charge, then perhaps that's the case. However, most long-term care facilities will have a chain of command where you would report it to the director of nursing or to the administrator. Because not only is it going to be, if it is an institutional abuse, not only is it going to be a report to DHSR, but it can be a criminal case as well. One of the things that you need to be very aware of is that anyone can call DHSR, and in fact, families are informed that they have that right whenever their family member is placed in that facility. So DHSR will investigate alleged abuse or reported abuse, I should say, for someone in an institution like assisted living or long-term care facility at the request of a family member. They will also investigate it in hospitals. But typically, if they're in an institution, DHSR is the agency. If they're in the home, then Department of Social Services or the Adult Protective Services would be who it's reported to. Let's go back for just a little bit and talk about the genital mutilation. What am I talking about when I'm talking about female genital mutilation? Why is it done?
Where they try to, I guess, I use alter, not alter the parts to prevent reproducing later.
Or actually, a lot of it is to reduce sexual pleasure. Because they typically will remove the labia or the clitoris. And then either sew the vagina shut to prevent premarital sex. Why is that problematic other than it's a human rights violation? Infection.
It's usually not doctors doing it.
Okay, what else can happen? What does it contribute to if the person does become pregnant? What are they more likely to experience? Tears. What happens to the fetus? Likely to die. It increases newborn deaths. Because if you think about it, if you've got someone that has undergone that procedure and you have got that vaginal opening that's sewn shut, what does that do to the increase in risk for anoxia for that infant? It increases it because there's no opening for that kiddo to come out. So you may have anoxia for the child because of the amount of scar tissue and tearing that occurs with that birth trauma. Okay, let's talk about child abuse. What are some of the characteristics of abusive parents? They experience child abuse as children themselves. High stress, unemployed. They may blame others for their problems. What else is a big factor, guys? Drug and alcohol. Very poor problem-solving skills, low ability to tolerate frustration. The most common type of child abuse is what? Neglect. And then physical and sexual and emotional. Who is most likely to abuse children?
Mother.
The parents. It's always sort of floored me that we talk all about stranger danger, and then it's not really stranger danger that you have to worry about so much as it's your own mom and dad. What are some of the indicators of neglect that you would assess for? Failure to thrive, okay, meaning that they're a 6-month-old that maybe weighs 12 pounds.
Child in school who's always hungry and asking for time to get more food and not wearing appropriate clothing.
Not wearing appropriate clothing,
Frequent absences.
okay. Maybe their mother doesn't have the 65 rule for the rainbows. Or that may be that they don't have any other shoes. What about overindulgence? Is that a form of neglect?
Yes.
Well, we all have done it too. Because we all want them to have more than we get. But sometimes that's not the best thing. But there's a difference between overindulgence on occasion and overindulgence every day. And in fact, I think we saw that, I don't know if you followed this case where there was a, I can't remember if this guy was driving a very high-powered sports car and hit someone either in another car or as a pedestrian. He gave this young man probation for vehicular manslaughter because of what they termed affluenza, okay? Meaning that he had always been indulged. Very rich parents, he always got a different car every year. He had never had to accept the consequences of his actions, which I thought, well, why are you letting him off now whenever this is when he should be accepting the consequences of his actions? You're just indulging this young man just as much as his parents did. But he got 3 months probation for vehicular manslaughter. What types of things do you see with children with emotional abuse?
Low self-esteem,
Low self-esteem,
shy.
very shy. How do they interact with other people or other adults? Very distant with them, okay? What do we look for with signs and symptoms of physical abuse? What types of things?
Bruising on their extremity.
Bruising, not necessarily on their extremities, but where?
Thighs.
Okay.
Hyperactive.
Centrally located, usually in areas that don't typically show. Injuries that don't go along with the story that they tell. Okay, remember there is just two stories are not congruent. Be extremely suspicious if you have a child that is non-walking that has a lower leg extremity fracture. Spiral fractures for that, you see that twisting, that's another
Old and new.
old and new fractures. Small arm. That jerking with that brachial plexus. What other types of physical abuse are there besides just battering a child? Emotional. You can't do anything with it. I don't know why I even had you. Or it's like this guy that we had where his mom called him on his birthday and told him, I wish I'd had an abortion. What are some of the signs that you see with physical abuse that you'd be highly suspicious of? Like little round cigarette burns. What about the stocking glove or the hand with the burns of scalding water? What's the difference between whenever I see someone from a different culture with those cupping or the pointing, how can you tell the difference between that and abuse? Right. Well, this poor guy that the football player that whipped his child with a switch. Have you seen the pictures of those?
Yes.
They were bloody welts. Typically, one of the definitions, just as an FYI, that they use for spankings, if the bruise or the impression lasts more than 24 hours, it's considered physical abuse. And that's the difference between spanking and abuse of a child. But the cupping, what do you see with those types of treatments for these children for respiratory illness? Those little round rings that sort of look like octopus suction cups, okay? Pointing, typically what do you see?
The red marks,
The
scraping.
marks, where they've tried to get the wind out of them.
This isn't child abuse.
That is not child abuse. It's just a cultural phenomenon. It's not bruising, it's just marks on their skin.
But you wouldn't expect that to last.
That doesn't last for more than 24, 48 hours. What about shaken baby?
You want to check for
Retinal hemorrhages? What else do you see?
Subdural hematomas.
Subdural hematomas,
Fractures.
fractures of the ribs and maybe arms. You may also see bruising with the finger marks. What do you usually worry about with shaken baby syndrome with those subdurals? Brain swelling. Typically what happens if they do survive that incidence of shaken baby? Cognitive problems, blindness, deafness, paralysis may occur. Now, what is Munchausen by proxy?
It's when the parent thinks,
The
Says the
parent
child is
does
sick.
what?
takes the child in
All
for all
right, you
kinds of.
guys, quiet back here. Say something. What is Munchausen by proxy? The parent does what? They do something to the child that makes them sick. Why do they do that? The attention. Who typically is the person that does the Munchausen by proxy? The mom. And usually where does they work? They're often in healthcare. What are some of the things that would make you suspicious with Munchausen by proxy? Better and then worse.
Dr. Hopping.
Doctor hopping maybe, because the mom is wanting to make sure that they get all these medical tests and will continue to do that until they find a doctor that will do that for them.
If they hear good news, they don't want to.
They don't get better, even though the treatment, you know, if it's a E. coli infection, then you would think that they would get better with antibiotics, and then they get almost better, and then they get worse again. Okay? What is the difference between Munchausen by proxy and just the situational child abuse? What's the big difference?
The child will eventually
Maybe if they survive the situation, but there's a difference. Most is premeditated. Munchausen by proxy is premeditated child abuse. Most of other situational abuse is not premeditated. However, it may be careful in that they are careful where they hit that child or perform that abuse so that other people are not seeing it. But Munchausen by proxy is premeditated. What is incest? Relations between family members. Okay, remember that it often is, it may be a parent or step-parent, but it also can be siblings or step-siblings. Child abuse and child sexual abuse reportable?
Yes.
Always. Who do we report it to?
DSS.
DSS, Child Protective Services, or your supervisor? Who is it required reporting for? Teachers.
Under 18 and
Nurses, teachers, any healthcare workers. Some states, it's anybody in the community. What don't we want to do whenever we're interviewing a child that has possibly been abused or
Don't sit in front of them.
sit beside of them,
And maybe get them away from them.
getting away from a parent or caregiver or whomever the person that possibly abused them? Do we want to say, I want you to take off your clothes and put on this gown? Okay, if they're comfortable, maybe, but you have to, that's not the first thing that you're gonna say. You need to establish a relationship. What do we want to do whenever you're doing those interviews? Do we want to do it in a busy emergency department? Okay?
And let them talk, don't.
Let them talk, don't force them to say what they don't want to say.
Don't have any expression that make them feel like they've done something wrong.
Right. And reassure them that what they've done is not wrong. Okay. All right, what's the period of purple crying? What's that used for? It's to help decrease the incidence of shaken baby syndrome. Why is the period of purple crying effective in helping decrease shaken baby. What's one of the most common reasons that infants are shaken?
Because the parents don't know why they're
They're
crying.
crying or irritable because of colic or some other reason, and the parents have unrealistic expectations of what their developmental process is going to be. Or the child may be developmentally delayed. Alright, so intimate partner violence, what questions do you have about that? What are some of your KDODs on intimate partner violence?
Cycle of violence.
Cycle of violence is one, but as the nurse taking care of this patient, what are my priorities?
Safety.
Okay, what else? Non-judgmental. Resources. Emotional support. Do I force them to say, you really need to report this?
No.
Is it a mandatory report?
No.
No. Unless they're within one of those protected age groups. Okay. Why do women stay in abusive relationships or men stay? Fear. Finances, fear.
Thinking they'll change.
Thinking they'll change. Why do women usually leave?
Children getting away.
Is that a safe time after they've left?
No.
No. Usually that's whenever most of these homicides occur, is when they are leaving or just immediately after they've left. What type of safety plan are you gonna help these people develop?
Escape.
Place to go,
Make sure
a
they're
bag
back,
packed,
have their report on.
having their documents available if they can get a hold of them, because remember, sometimes these are locked up so that they're not able to do so. All right. Lastly, sexual assault, and I'm hoping that Ms. Rummel is gonna be down here. What are some of the KDODs on sexual assault? It's power and control versus a sexual act. What about with your date rape drugs? What are the things you're gonna want to remember with nursing care of those folks?
Airway,
Airway on a couple of them.
urine,
Urine, drug screen, to screen for drugs.
Let them make the choices.
Let them make the choices and be in charge. Now, you may have to prod just a little bit at first, especially if they're in that very high anxiety stage.
amnesia.
You may see that they have amnesia. They may have no clue what's happened, especially with ketamine or Rohypnol. You'll need to get consents for collection of the specimens. What else are we going to do physical care wise for a victim of female victim of sexual contraception?
Prophylactic HIV.
Prophylactic HIV and sexually transmitted disease for any victim of sexual assault, whether it be male or female, child or elder. Typically, your elders, you don't have to worry about pregnancy, but STDs or STIs, you definitely do need to worry about. Therapy for batterers, effective or no?
No.
If they admit it.
If they admit that guilt and commit to the treatment, it's more effective than it would be if they were one of those intimate partner terrorists, okay? What about therapy for rapists? Not particularly effective, okay? All right, any questions about, that is what's gonna be on the test on Wednesday. This is 212, this is our first test.
Yeah, I have a question. Where, when we were talking about the women might fill up their vagina for whatever reason,
about very first of the topics that we're going to discuss today. Yeah, I recognize this is over 100 slides, but it probably will be 4 hours of content. Okay, so next week we will talk probably about sexual abuse and sexual assault, the last 2 hours or so. What we're going to talk about today is focusing on some specific populations with abuse. One of the things you need to recognize is abuse is not just children. It is just not the elderly. It is not just intimate partner, okay? And intimate partner violence, or IBP, basically is the new terminology for domestic violence, okay? Because not everyone is married. It's not spousal abuse if it's boyfriend, girlfriend, or teens, okay? So intimate partner violence is the new terminology that you're going to hear. One of the things you need to think about with spousal abuse and child abuse, it arrived in the United States with the Puritans, okay? But it was not until about 1973 that public outrage initiated that focus on developing laws for protection of both intimate partners as well as for children. So not until about 1973 was it recognized as a crime, okay? Which is sort of scary because that's not that far in the distant future. At least for me. For some of you it's ancient history though. Basically, in '87, Congress passed amendments to the Older American Act of 1965. Remember that Older American Act in '65 is whenever Medicare was developed. And basically what that did is it provided for state agencies of aging to assess the need for elder abuse prevention. Okay, there wasn't a law against it. It's just assess the need for those agencies. Historically, what we've seen is that violence against female partners has not been considered a social problem, but rather a fact of life. And I think that that is significantly changing. Those of you that have been following the news recently with the Ray Rice video that was released, you know, initially, before they saw the full video, okay, as he's dragging her out of the elevator, he only got a 2-game suspension. But when they saw the full video, basically he is suspended for the season. However, the football commissioner says that there is a possibility he can come back, depending on the outcome of the trial, if there is a trial. Because one of the things that you will see is that there probably will be a trial on this one. But with intimate partner violence, charges are not automatic. Charges are automatic with child abuse or elder abuse if it's reported. But what you will see with intimate partner violence, it is up to the partner to bring charges. And they have the option of not doing so. The exception to that is if a weapon was involved or the person was beaten so severely that they have life-threatening injuries. Okay? That's the difference. Yes?
I know somebody who was in a domestic violence situation and she refused to press charges, but they told her that she didn't press charges and the state would.
It depends on how severely she was beaten, okay? And that is the case, unfortunately. With the Ray Rice video, it depends on what you find the laws in the state where that happened.
So the guy that they just found, his 5 children in Alabama, they haven't decided what his charges are going to be yet. So is it they're just determining what to charge him with?
Well, they will, okay? Yeah, he will be charged with murder of those children, okay?
But which state to charge him in?
Probably what you will see is that they are going to determine where the crime took place. More than likely, from what I was listening to the news, they say that it took place in South Carolina, so the bodies are being brought back to South Carolina for the medical examiner. Yes?
Hi, I just want to let everyone know that we're downstairs doing the blood drive until 1:30. You guys nursing students? Okay. So you guys aren't scared of needles?
Yes.
20 people?
We are.
Not for other people, but for us, yes.
Well, our goal is at least 20 people. We're really short on blood. So if you guys would come donate, that'd be awesome.
Is food involved?
Food, free
Okay,
t-shirts,
that might have something.
drinks.
I'll be down. I might have a song.
Please come.
That's okay.
Thank you.
Peace.
So, what you will find is that it will depend on what state. That's one of the things that you will find that's so random about these abuse laws, is there is not a federal or national law, okay? Each state has their own set of laws that you have to be familiar with. Now, whenever I talk about legal today, we're going to be talking about North Carolina. But from what they understand, he transported the bodies from South Carolina to where they were found, and that's why they're bringing them back to South Carolina for autopsy. All right, so what is the role of nursing in caring for people that are victims of abuse? Well, what you see is that often nurses are the first one that interacts with this person in the healthcare system. They may be met by a nurse in the triage unit in the emergency department. They may be met by a nurse in that clinic. They may be met by a nurse in that physician's office. Okay? So it's extremely important as nurses to try to help detect and provide effective intervention for those clients that have experienced abuse. The other thing is that nurses are key with prevention. How many of you have watched the period of purple crying? Okay? Period of purple crying basically is and I've got a slide a little later on, it's a video that CMC has all of their new parents to watch. Because what it does is it helps them deal with very crying, irritable babies. Because one of the things that you will see when we talk about shaken baby syndrome is that babies that experience colic, that have developmental delays, that are premature, are more likely to be shaken and experienced child abuse because of that. So that period of purple crying was developed to help new parents understand what they can expect from that newborn infant. And it also gave them some ideas on how to deal with that child so that hopefully they'll go to sleep and the parents can get some sleep. Okay? But that is a preventative measure that was developed by a group of nurses and physicians to educate new parents about babies and crying and what you need to do about it. Now, what you will see is that abuse, basically, it's a pattern of behavior that dominates and controls, okay? Those are two key words, domination and control. Basically, what you will see is that that abuse lowers the self-esteem of the person that experiences it, and it takes away their freedom of choice. It limits their choices that they have. Now, with interpersonal violence, you can see violence between family members or friends. One of the things that you will see is that a lot of people feel that intimate partner violence occurs only in people that experience poverty. That is not the case. You see it in all societal levels. What you find is that the rich tend to be able to hide it much better because they have the opportunity to do so. Interpersonal violence accounts for about 11% of all the violence in the United States. Okay? Gender-based family violence. That would be your intimate partner violence, your child abuse. Typically what you will see is that of that family violence, 49% of that is directed at spouses or other partners. 11% is directed at children. 40% is directed at other family members, like in-laws or grandparents, those types of things. Okay? So that what we see is often these folks come to the emergency room, and what you find is that their visits for injuries being attributed to being accident prone. Now, I'm not going to say that some kids are not accident prone. If you got boys, you understand what I'm saying. Or girls that like to ride horses. But what I will tell you is that, yeah, if this kid is showing up in the emergency room, but different emergency rooms typically on a fairly routine basis with injuries that can't be explained, then that's a pattern that needs to be investigated. The other thing that you will see is that a lot of times what you will see is these patients come in with signs that reflect high anxiety and chronic stress, hyperventilation, panic attacks, GI disturbances, particularly vomiting, diarrhea. You may see hypertension, sometimes physical injuries, but depression, okay? Remember, one of the things that Ms. Rummel probably talked about yesterday with depression is that stress and not having the coping skills to be able to deal with it. Other things that you might see, insomnia. A lot of times these folks that experience violence have insomnia because they're so hypervigilant because they're afraid to go to sleep. Violent nightmares. A lot of patients that experience abuse have PTSD. It doesn't only occur in soldiers. It does occur in our generic population as well. Anxiety, extreme fatigue, eczema. Doesn't mean everyone that has eczema is being abused, but it is a sign of high stress. It can also be genetic. Loss of hair, either from pulling it out, okay, and a lot of times you will see people with bald patches because of that anxiety. course, with some men, loss of hair would cause anxiety. Others, you just need to look at your dad and say it's all your fault. All right, some of the theories behind abuse and violence, just sort of as a general overview, guys. Neurobiologically, what they look at is serotonin levels. Serotonin basically calms through inhibitory control. What you will see is that some people that have a fairly low level of CRF, or corticotropin releasing factor, basically what you will see is that those people are extremely violent, because CRF is a major regulator of stress responses. There is a book that I read last year that was really very interesting about violence and criminal behavior, and they've done a study and they've shown that a lot of patients, not patients, but a lot of people that perpetrated horrific acts of violence, serial killers, had extremely low levels of CRF. One of the things that they are pursuing is there something or a drug that can be developed that would increase that CRF to increase their ability to deal with stress and hopefully not exhibit that in a violent manner. Now, there are interpersonal theories. Basically, cause lies in the personality of the abuser. And I think you probably saw that with some of your antisocial personality disorders, the little skits that you did. Basically, what they feel with this theory is this person lacks self-regulation. They have very poor problem-solving skills. This theory probably is not as recognized or influenced so much as the social learning theory. That's the one that the majority of your sociologists and psychologists sort of adhere to now. They feel that violence is a learned behavior. Okay, children do what they see. They mimic what they are a product of their environment, so to speak. Basically, conditioned to respond aggressively and violently, they learn from observation and victimization. Another big focus right now with social learning theory is the video games out there. You know, what they've done is they've rated those video games. Some of them are mature, meaning that, you know, Grand Theft Auto and a lot of the fighting games are rated as mature games, and they're not for children. However, I would say that a lot of parents do buy those because, and children use them, but some parents just don't regulate. So one of the things that you're starting to see is in court is the video game defense. Grand Theft Auto made me do it, so to speak. And that is a concern. You know, I've not seen very much evidence, but people that do use that as a defense sort of subscribe to this social learning theory. Now, one of the things that you will see that a lot of people do believe, and I really subscribe to as well, is that some cultures and communities value subordination of women. We talked about this a little bit when I did the culture thing about the patriarchal society, where the male is the head of the household. Often women are viewed as, and children are viewed as property. Okay? So that basically you do what I say or you will suffer the consequences. It is a power issue, and what you will see is that those victims do learn to become codependent. A lot of times it is a cultural norm, however, and it's very, very difficult to break that cycle. All right, enough about theories. Let's talk about risk factors. Sad to say, but children that have disabilities are at higher risk for abuse. Why do you think? It's more stress on that parent or caregiver, okay? Younger children are more prone to serious injury and death. They're more prone to shaken baby syndrome. I don't know if I told you or not, but under the age of 1, the biggest cause of death in infants is abuse. Under the age of 1. And I will tell you, it's pretty high on children under the age of 4 as well. Between abuse and accidents, #1 cause. It also can be related to gender. There are similar levels of maltreatment for boys and girls when we're talking about physical abuse. However, girls are 4 times more likely to be sexually abused. However, I think that's probably changing, and that will be more equal in the future as well. Women do experience more intimate partner violence. That is also changing. We're seeing a large number of men that are being abused as well. Typically what you'll find is that men experience more street violence, i.e. gangs, or bars, or wherever. That is also changing. The number of women that are in gangs or experiencing fights at Verizon Wireless or wherever, okay, is dramatically increasing. So it's going to be one of those things that we're just going to have to watch out. You know, you screen everyone for violence against them. Not just, I don't have to just worry about the woman anymore. I have to screen everyone. Now, with some of the psychological risk factors, they are going to contribute to and have consequences of violence. Poor coping skills. What type of coping skills have you seen, those of you that have already been to psych, what kind of coping skills have you seen with the clients that we've cared for?
Aggression. Yeah.
A lot of times aggression, a lot of times substance abuse. Okay, that's a coping skill. Drugs or alcohol. Cutting. Picking. I mean, I've seen people just pick scabs and make big holes in their face. Isolation.
Pacing.
I'm sorry?
Pacing.
Pacing. That's a way to relieve stress. But think about drugs and alcohol. What do drugs and alcohol as a coping skill do? Increases aggression. Because what does it do? It removes that control of the inhibition of the limbic system. One of the things that you will see is that violent behavior basically is controlled by that limbic system. And the frontal lobe basically tamps down that aggression. What we see with drugs and alcohol is that they remove the control of the frontal lobe. So you have that limbic system that's cycling that violent thought or behavior without that inhibition. Okay? So drugs and alcohol definitely is a poor coping skill. Or one of the other thing is that the only coping skill that they ever saw their dad do was when mom talked back, smacked her upside the head. Learned behavior. Emotional client, the family or distribution of power in the family. instead of being equal partners, if dad has all of the power, what dad says goes. Now, what do we as moms do to sort of contribute to that?
Wait till your daddy
Wait
gets
till your
home.
father gets
Wait till
home.
he hears this.
Poor dad, he was always the bad guy. He was always the bad guy. My husband, what do I do? Send her to her room. My little girl was always a daddy's girl. So she always was much more upset if dad was upset with her. Typically what you will find is that impulsive behavior, again, that inhibition of the limbic system, okay? Some abusers argue that they lose control. You know, I couldn't deal with it and I just lost control. But if you look at that, rarely do those people choose to hit their bosses or policemen no matter how angry. Now some do, but typically what you will see is that often these abusers plan where in the home, when no one's around, and how they inflict. Typically what you will see is that when it first starts out, that violence is where it cannot be seen. Under clothes that can easily be covered up. People that initiate violence consider their needs to be more important than anyone else's. And they look forward to others, they look to others to meet their needs. Okay? Now, things that are related to culture, women that are at greater risk for interpersonal violence in patriarchal societies. You see that in a lot of Asian, African, as well as Arabic cultures. Basically, the status of being the patriarch of the family grants the men the financial or physical control. And that was the case in the United States until basically the 1900s. Women could not own land until about 1910. If your family, you inherited land from your family, it automatically went to your husband's name because you were not allowed to own that land. It's changed quite a bit. Now, one of the things that we see specifically related to culture, World Health Organization as late as really about, I would say 1990s, issued a statement about female genital mutilation. Basically what you will see is that some cultures intentionally alter or cause injury to the genital organs. Some of the procedures that are done include removing the labia, removing the clitoris, and in fact sewing up the vaginal opening. Okay? Basically, menstruation is considered unclean. A lot of cultures would have prohibitions of the women being around men during menstruation week, or so to speak. What you will see is that, of course, removing the clitoris, removing the labia, or sewing up that vaginal opening can cause severe bleeding, problems urinating, cysts, infections, infertility, complications in childbirth, Because one of the things that you will see with sewing up that vaginal opening, what do you think that that tissue is going to do? It's going to scar. Okay? And basically what we see is increase in newborn deaths. Now, these surgical procedures, or these procedures, are not carried out by medical professionals. The majority of them are not. Only about 15% are. Typically what you will see is that the healer or the granny woman or whomever in that culture is the person that carries that out, not in a medical clinic. So you can imagine that bleeding and problems with infection are significant. One of the things that you will see is that the age of the mutilation will depend on the culture. Infants to about age 15 are the usuals. Typically what you will see, most cultures will do this around 8 or 9 years of age prior to the onset of puberty. Okay? World Health Organization basically came out with a statement that female genital mutilation was a violation of human rights against girls and women. And it is a practice that is frowned upon. However, what they've basically been able to do is to say that they don't want healthcare professionals to participate in it. However, what you will find is that there will still be women that undergo these procedures, and we are starting to see a lot of them after they've migrated to the United States. So it may be something that you would come across in your own practice. Okay? All right. Some other things we need to consider. Risk factors, child abuse and neglect. Now, remember I said these are correlates. They are not causes. Poverty, violence in the family, prematurity or low birth weight, unrelated male primary caregiver. And I think that we have seen that recently in the news. An unrelated male primary caregiver is one of the most significant risk factors for shaken baby syndrome. A young, unrelated male primary caregiver. Parents that were abused as children, again, it may be a learned behavior. Child disability, parental substance abuse or social isolation. Things that will increase sexual abuse. Absence of a natural father or having a stepfather. Being female. Mother's employment outside the home. How many families can get by on one income now? Not very many. Poor relationships, parental relationships characterized by conflict, and then again, substance abuse. 17.9% of North Carolinians live in poverty. Okay, so what you see is that these, again, are correlates. That doesn't mean that everyone that's poor abuses their kids. No, they don't. But it greatly increases the risk because of stress. Now, one of the things that you will see is that for the elderly abuse, it's sort of counterintuitive. Basically, the risk that an elder is going to be abused increases whenever the abuser is financially dependent on that elder, okay? I.e., son is unemployed. They depend on mom's house, mom's social security check to get by. The risk increases. It's 5 times more common in households where the income is less than $15,000, greater than $50,000. Does that mean that it doesn't occur in these 50,000? No, it doesn't. It means the risk is less, but it still does occur in all income groups. Substance abuse, again, it also increases the risk for intimate partner violence. It increases the risk for child maltreatment. Some other things, just as an FYI, divorce and custody battles. Basically, one of the things that people don't recognize, they think child abuse equals physical. It doesn't always. Emotional and verbal abuse is just as harmful. It may not be life-threatening, but it is just as harmful to the psychological development of a child as physical abuse. Gang violence, social rejection by peers, and I think we've all seen what happens with that social rejection for peers. What does that do for that child's risk for suicide? Greatly increases it. Okay? Now, one of the things that you'll see is the availability of lethal weapons. That does increase the risk of violence. One of the things that we tell women or people that are being abused from intimate partner violence is that if you are being abused, do not go in the room where there are weapons available. Stay out of the kitchen. Stay out of the room where the guns are hidden, because that will greatly increase your risk of having a life-threatening injury. Okay? Questions about that so far? All right, I'm going to start off with elderly abuse, and then we're going to take a break right at 10 o'clock. Basically, abuse of elders was unrecognized until the late 1970s. It's thought that for every 1 case that is reported, there are 5 cases that go unreported. So about 70 to 80% of your cases of elder abuse are unreported. From 1986 to 1996, the number of cases that were reported rose 150%. So if the cases that were reported rose 150%, how many cases do you think went unreported? What the statistic would be? About 1,000%.
Oh my God.
Okay. Elders are more likely to report physical and sexual abuse, and they are less likely to report other types of abuse. Now, what you will find is that with that 1965 law that recognized the need to consider elders as a protected category, what you will find is that, again, every state has a different law as to how they consider the filing charges for elder abuse. Now, just to give you an example, Iowa and Oregon include age as a hate crime. North Carolina basically considers it not as a hate crime, but as an aggravating factor for sentencing. basically what you will find in the state of North Carolina, an assault and battery on an elderly person basically will get double the sentence on someone that's age 24. It's considered an aggravating factor. Okay? They will get longer sentences. Different states have different laws, but again, Oregon and Iowa consider it a hate crime. Some of your manifestations, it may be very difficult to discern physical symptoms because often they may be masked by chronic or acute illnesses. How do I recognize the bruises that this person has experienced are because of a fall versus someone that would be
Where? Location?
location? It's like that old real estate thing, location, 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 okay? Typically, where would you expect bruises to be from a fall?
Hips,
Hips,
extremities,
arms,
extremities.
legs.
Yeah, all
Okay.
extremities.
Where would you expect it to be from an assault?
Back, stomach, back.
Chest, face, back, and really buttocks, okay? Areas that are covered up, that will be covered by clothing, are more likely to be where the abuse occurs. Now, one of the things that you'll find is that cognitive impairment may be difficult for you to get a true story of the abuse. One of the trends that we're seeing that scares me to death is that a large number of your patients with Alzheimer's disease or dementia of some type are being abused because they can't tell a coherent story, okay? And as the number of people that develop Alzheimer's or dementia are increasing, we probably will see more and more of that. That's why it's extremely important to get these caregivers some help because of the amount of stress. Aphasia. Okay, remember aphasia is the inability to talk, either speak spoken words or understand language. Again, they can't communicate what's happening to them. Agnosias. And remember, agnosias are the inability to recognize objects or faces. Okay? So they may not be able to tell who this person was that perpetrated violence against them. Apraxias. Inability to execute learned purposeful movements. They can't defend. Now, with elder abuse, the presence of fresh or healing injuries, always there's the need for further investigation. Why did this happen? How did this happen? And one of the things that you will see is that often the stories will be different, and that should give you a very high level of suspicion. There are 5 kinds of abuse. Physical, that's basically hitting, slapping, bruising, sexually molesting, and restraining. That is why whenever we put restraints on someone in the hospital, you better have a doctor's order, and you better have that order renewed every 24 hours. And you better do those checks. It is illegal to restrain someone against their will unless there is a medical reason. I don't know, about 15, 20 years ago, 2020 did a expose on nursing homes and had, you know, all these older people restrained in their chairs, and they were talking about how horrible the restraints were and they never got to move, and et cetera, et cetera. And a friend of mine was watching it with her mom, And she said, Myra, you got to promise me you'll never put me in a nursing home where they'll tie me down. And Myra jokingly looked at her and said, Mama, why would I put you in a nursing home? I can tie you in a chair here. She said her mother did not speak to her for 3 weeks. So, and of course Myra said, Mom, I was joking. You don't joke about that. Which sort of brings me to this one. Psychological abuse. The infliction of mental anguish, humiliation, intimidation, and threatening. And one of the things that you will see is that we as nurses need to be careful about is this one. If you don't get in that bed, you're going to fall. Or other things. I am going to give you some medicine that's going to knock you out. Yeah, you may want to. You may have to, but you don't threaten them with it. This is a big one right now, guys. We're starting to see more and more and more of this. Financial abuse or exploitation. Misuse of someone's property and resources by another person. Whether it be one of the caregivers in the family, or one of the things that we're starting to see, and I know you've heard about in the news, is granny exploitation, where someone calls this woman and said, Grandma, this is so-and-so. They say the name of the grandson. I'm in jail. Can you wire me some money? And of course, it's not their grandson. It's someone that is scamming them. There are a lot of telephone scams that do target the elderly. There was something in the Charlotte paper where this gentleman had basically bought $3,000 worth of those cards, the money cards. And what he did is the person called him back and he gave them all the numbers. So basically he lost $3,000. So one of the things that we're starting to see is that there is legislation in place in the state of North Carolina to make that more of a crime because it's being perpetrated against elderly people. Okay? Where they may not have the resources to fully investigate. Neglect, failure to fulfill a caretaking obligation to provide goods and services. Now that can also include self-neglect, where the person is not able to care for themselves because of a mental or physical disability. In the state of North Carolina, if you are over the age of 18 and have the means and opportunity, you can be fined by the state for not caring for a parent that has a need. It's a fine. It is not jail time. But something to think about.
Even if you're estranged?
Even if you're estranged. What you would have to do is prove the reason for the estrangement.
Okay.
Now you can go to court and stand before a judge and make sure that that fine's adjudicated.
Okay.
But if you have the means and opportunity and don't make sure that you are caring for your elderly parent that has that need, you can be fined. Sexual abuse, basically non-consensual, either by refusal or incapacity to refuse. These patients that have dementia do not have the capacity to refuse sexual contact. How many of you work in nursing homes? How many of you know that there's a lot of movement at night through the nursing homes? Okay? One of the things that you have to do is to make sure that it is consensual. Okay? You, as a nurse that works in long-term care, you have to assure that that sexual contact is consensual. Just as an FYI, the biggest growing population for STDs now is people age 70 and above. You think about it, they don't have to worry about pregnancy, so how often are they using condoms?
And a lot of them aren't educated either.
All right, so these are the types that you see. More than likely, as a nurse, what you'll see most often is that physical abuse, the neglect, or sexual abuse. Typically, we don't see financial abuse or exploitation in the hospital. However, as you're doing discharge planning, you may see that someone is exploiting them. A lot of people lose their life savings because someone else takes control of the checkbook. Okay? Questions about that? All right, let's take a break.